All right, good morning, everyone. My name is Dr. Carolyn Custer, and I'm accompanied by Ms. Maya Campbell. If you are a CHW watching this module online, we want to share the QR code for the pre-evaluation. So let me go ahead and share our screen and we'll get started here. All right, Maya, can you confirm you can see?
Yes.
Okay,
Yes.
so this is the
Okay.
Wayne County Health Catalyst for COVID Care, Community Access, Response, and Equity. This is the pre-session evaluation QR code. So we're going to pause it here, and if you could go ahead and pause it as well, and either scan the QR code or the link to the pre and post will be available below. This would be very helpful. So we encourage your participation in this, and we'll be back in just a few minutes to start the session. Oh,
Thank you.
hold on one second. I don't know how to. All right, so welcome everyone. We're so excited to have you join us today for this training. We're looking forward to engaging with you. I'm Dr. Carolyn Custer. I'm the project director of this training. And so this material was put together by myself and Maya, and I'll go ahead and let Maya introduce herself.
Hello, my name is Maya Campbell. I am with MISHWA. I'm the membership and registry specialist here at MISHWA. I am also a very proud community health worker. So we're so excited to present this training for you today.
All right, so we'll go ahead and get started. So on the agenda, we're going to do an overview of health literacy. We'll talk through 5 health literacy and intervention specific, take a short break, come back, talk about vaccine hesitancy and COVID-19 specific, and wrap it up with an interactive case discussion, hopefully. The learning objectives today, you'll at the end be able to describe health literacy as a social determinant of health, and then identify strategies to address it, including culturally and linguistically appropriate standard services and some other culturally competent care. And then at the end, understand causes of and identify strategies to mitigate vaccine hesitancy. So we can't start with, we're going to go ahead and get started. We can't do a training about health literacy without talking about equity, health equity. Has anyone seen this slide before where they show the boys? So this is a pretty common slide that a lot of people have seen, but it shows the difference between equality and equity. In equality, of course, everyone gets the same thing, right? So everyone's equal. But you can see that that doesn't necessarily always remedy or mitigate the circumstances. Equity is giving everyone what they need to succeed. So it may look different for different people, but we're going to take it a step farther now. So this slide shows us equality, equity, and then the concept of justice. And as community health workers, you're all too familiar with social justice, and this is the thing that we're working on, right? So how do we remove those systemic inequities and the systems that were built with barriers in the first place? And how do we make it just for everyone? So health literacy is one of the social determinants of health. As you may be aware, these are the things that can impact health that aren't necessarily clinical or medical, right? So the things where people live, work, and play, things like having a safe neighborhood to be able to exercise, having transportation to get your medication, food, these are the things that are necessary for a healthy life. So this is the context that we're going to start building when we talk about health literacy. And I'm going to turn it over to Maya.
Thank you so much, Dr. Custer. So what is health disparities? So the CDC defines health disparities as preventable differences in the burden of disease, injury, violence, or opportunity to achieve optimal health that is experienced by the socially disadvantaged populations. This exists because health inequities and factors like social determinants of health, like Dr. Custer mentioned, and systems designed with structural racism. Thank you so much. So health literacy in Wayne County. As we know, historically, Wayne County has been redlined. So is everyone familiar with that term, redlining? So redlining does negatively affect the quality of life of those living in the specific communities because they are cut off from resources. So they don't have access to doctors' offices and hospitals. The history of healthcare in Detroit, as we know, if we can look at the map, the redlining are specific communities that were kind of cut off or had less resources, and also access to education was lower in these communities as well. Okay. So what does health literacy mean? So if we can just touch on this brief bullet point, what does that mean to anyone?
Does anyone want to say?
I'm sorry, go ahead.
This is your slide, Maya.
That's okay. So does anyone want to unmute and say what health literacy means to them really briefly? Like when you hear that term, what does that mean to you?
I don't know if anyone's talking, you're all on mute.
That's okay. Well, when I hear health literacy, prior to being a CHW with the insight on what health literacy truly was, I probably thought that it was understanding like what my doctor was talking about at the doctor's office. And that made me health literate because I understood some of the medications. But as we know, and what we'll get into later in the training is that it's much deeper than that. So Dr. Custer, do you want to touch on the Healthy People 2030?
Sure. So, every 10 years, there's a Healthy People report released with goals for the nation. And in 2010, 2020, personal health literacy was part of that. Personal health literacy depends on the individual or the patient being able to find, understand, and use this information. And we'll go more deeper into that in a second. But in Healthy People 2030, they added the definition organizational health literacy. So we know that it's not only on our patients or on our members to understand things, it's on us to explain things in a way that are equitably and easy to understand. So it's just important to note here that it's a joint effort. Everyone has to be part of making organizations and improving health literacy. Okay.
Yes, thank you. Okay, so the health literacy components that we'll discuss, the skills and knowledge needed to interpret health information, and literacy. What is the true or the deep down definition of literacy? Reading, writing, basic math, speech, and comprehension skills. Numeracy, understanding math and numbers. That is definitely my Achilles heel. So we'll discuss that a little bit. Factors that impact health literacy. The complexity of the health information. Is it really detailed and difficult for the patient to understand? Language, is there a language barrier? Is English their first language? The age of the patient, and also the state of their health. Are they anxious or nervous? And also their cultural background. Another component is the way that the health information is being communicated by the provider.
So that's our focus today.
So this just gives a deeper background or deeper another graphic of that, those individual factors like literacy, health knowledge, demographics, cultural experience. And then on the right side, it shows a system and professional factors, public health practice, the communication and dissemination of that information, the public health infrastructures, and the public health workforce. So this is just another graphic of what we've talked about. And then all of this together combined is health literacy. So it's a combination of both the things.
Okay, so we're going to talk about some impacts of limited health literacy. And you have maybe seen these when you're out doing your good work. So people with limited health literacy are less likely rather to use preventive health services. Things like Pap smear screening for cancer, etc., vaccination. less likely to effectively manage their chronic disease like high blood pressure, diabetes, etc. There has to be a certain level of understanding of your condition, right, to be able to effectively manage it. More likely to have poor medication adherence, higher rates of hospitalization and use of ER for primary care, higher mortality rates even. This one can really impact people, reporting a sense of shame about their health literacy. We'll talk about red flags for low health literacy in just a minute, but the patient that maybe just nods, right? Do you understand? Yeah, you're talking to them and they're just nodding. Any questions? No questions. That could be due to them having a sense of shame. So we really just need to look out for those types of red flags. And of course, these are all associated with higher healthcare costs and expenditures. Then we take a look at community health literacy. So not just an individual person, but what does it look like on a community level? So some of the things could be missed opportunities for services, such as, like I said before, vaccines or preventive screenings, lack of preparation for emergencies like disasters, missed warnings about environmental and safety things like water, or food safety if there's an outbreak of some sort. So these are just some of the things that can happen on a community level. So we say, okay, thank you, Maya, for the definition of literacy. How does that relate? How are literacy and health literacy related? So you have to be able to have some level of reading to read, right? To understand these medical things. So the average reading level in the United States is 8th to 9th grade. But most health education materials are written at 10th grade or higher. So this presents a problem. So what we recommend generally is that the best reading level for materials is around the 5th to 6th grade. So whether you're selecting materials to use or you're making them yourselves at your organization, making sure that the materials are easy to read at the 5th to 6th grade level is very important. And by the way, I'll say this, we didn't say this at the beginning, but if you have any questions, please feel free to put them in the chat or, just ask us. Oh, I think we might have just had another person join. Thank you for joining. Okay. So here's some red flags like we just talked about. If you're working with a member client and you notice some of these behaviors, that could be a red flag that they're not understanding. Missing appointments frequently, incomplete registration forms, non-compliance with medication, which we talked about, asking about medications, unable to identify them, unable to give a thorough history, and then ask fewer questions. This is what I was talking about before. So there may not be any questions or a lack of follow through on test referrals. So any of these types of behaviors when you're working with your client, these are things that should trigger, hey, maybe this client has a low health literacy. So what do? We use a universal precautions approach. So universal precautions, I can't see everyone, but who knows about bloodborne pathogens? I'm going to assume everyone probably does. So bloodborne pathogens, remember in the 80s when HIV started becoming a big thing, you couldn't tell who had HIV based on looking at them, right? You can't. And so we develop protocols, universal precautions. So we say, okay, all blood is considered a bloodborne pathogen unless proven otherwise, right? So we just assume, so that's why there's so much safety around cleaning up blood and protecting yourself and wearing gloves and all that other stuff. The same way that happens for HIV, you cannot look at a person and assume what their health literacy level is. It doesn't matter how educated they are. It doesn't matter what their job is, how their income is. It varies, right? So the universal precautions approach assumes everyone has difficulty with or limited health literacy, and it forces us to communicate in ways people can understand all the time. And that's the goal, right? So we want to simplify communication, make sure that our patients are understanding and reducing the risk of miscommunication. And this will support our patients' efforts rather, to, empower themselves and take charge of their own health. And the more we normalize, the less we stigmatize. So this is a crazy slide. We're not going to go through all this, but these are the things to be considered health literate organization. These are the things that are in place. So you can take a look and see, you know, for your own organization, does the leadership prioritize health literacy? Are you using is health literacy at the top of mind with training staff, with putting materials together, with, you know, different types of things? So at the end of the day, all of these things contribute to being a health literate org. And all of these come from I wanted to bring this up, the AHRQ Universal Precautions Toolkit, which will be at the last slide with there's a slide with resources. All right, Maya, I'll turn it to you.
Excellent, thank you. So has anyone had experience with a loved one who has been impacted by low health literacy? Does anyone want to share an experience, or with a client or community member? Feel free to unmute. If not, I love to share. So if no one has anything to share, I can always share.
Maya,
I can
Okay.
say something.
Oh, go ahead.
Sure.
Like language barrier is such a big thing. So I can even talk, my mom doesn't speak English. So when she goes to the doctor and there's no translator, it's really hard for her. So I have to step in sometimes. But I think that would be an example of low health literacy because she can't communicate properly. So she doesn't understand half of the time.
Absolutely. And thank you so much, Fatima, for sharing that. I really appreciate you being open about that. And we will definitely dive into issues around language barriers and some guidelines around interpreters later in the discussion, but you're 100% correct. Language barrier is a huge, huge part of health literacy. Simply put, if you don't understand what's being communicated, it's not going to stick. So I thank you for stepping in and being that translator for your mom, but I love that you shared that because we will definitely get into that later in the training. So does anyone else have anything they want to share really briefly about their experience with low health literacy?
Well, I think like also going off of that, like when my grandma was in the hospital, like she also had like a similar issue with language, but I couldn't translate it because I wasn't understanding what it was saying. And so how do I translate that into something that's easy to understand when the words don't even translate like exactly the same way? So I think, you know, if you're not understanding what it's saying, like you can't even help your loved ones. And even with my mom, like she'll ask me questions and sometimes I don't understand it. So I start Googling like different ways to like explain it. And there's not a language barrier there. It's really just not understanding what they're saying. So.
Wow. Thank you so much, Andrea, for sharing that. I really appreciate your openness as well. I love doing these trainings, I just have to say, because each time we do these trainings and we open the floor for discussion, it's always something different. So that is a different point that I don't think that we've touched on yet, Dr. Custer, that there may be words that just don't translate. So wow, that's amazing. Yeah, but definitely that does definitely impact health literacy. So thank you again for sharing that. All right, is anyone else really quickly before we move on? Great, excellent. Okay.
Okay, thank you for sharing. All right, Maya.
Okay, so health literacy interventions. These evidence-based interventions are strategies are used to increase the patient's or client health literacy. It does create a health literate environment. Okay, so the first one that we're going to touch on is clear communication. So communication is like my most favorite thing. Like that's what I do for a living, is communicate. So I think of going to the doctor like an experience with shopping. It could be a great experience or it could be a really negative experience depending on many, many factors. So when I go to, let's say, the doctor's office or my shopping experience, air quotes, am I greeted warmly? Does the person make eye contact? Are they listening carefully to me? Are they using medical jargon or medical terminology that I just don't understand? Are they using my words? I think that's really helpful when you're listening to communicate back what the patient is saying in their language. Slow down. So I know that's really difficult for many of us. I put me in that category with us. It's easy to go into your spiel and not realize that your pace may be a little fast. So slowing down, limit and repeat the content. So just touching on what is important, be specific and concrete. Show graphics. Graphics are amazing. I always think about OBGYN offices where they show the different graphics and they have the models there. Those are very powerful because it does really help communicate that information. Demonstrate how it's done. I know that we did that a lot with diabetes programs, showing the patient how to use those testing materials. And invite the patient's participation and also encouraging questions. All right, so 7 things to consider when communicating about health. Trust. Does the person trust you? What is the relationship between yourself and that patient? The information that's being communicated. Is all the information that's being communicated, is it all necessary? Is it too much? Because information overload is truly a thing. Motivation. How relevant is the information that to the person that you're trying to reach? The environment. What are the conditions that surround and affect the audience? That's a big one. How is the patient showing up at the appointment? The environment is very important because we'll touch on it later. I don't want to give away our presentation, but capacity. What's the person's ability to act on the information? Are they facing any barriers? Perception. What would the audience think about the information? And what will inspire them to act? In response, how will people respond and what can they say and how can you encourage them to take action? And I'm sorry, Dr. Custer, I just took over our slide.
That's okay. Thank you. Those are all very important things to consider. All right, plain language. I'm sure a lot of you have heard of this and have learned this before, but of course, we try to avoid medical jargon. So instead of saying, hypertension, we say high blood pressure, of course, right? But just some of the other things like diet. I always bring this up, Maya knows, but if you ask a patient, what is your diet? They're going to probably think of either like Weight Watchers or Atkins or whatever diet, that people do. But what we're actually asking is, what do you eat, right? So just keeping it plain and direct. Even a word like adverse can be tricky for people. So it's better to say bad, for example. So you want to be to the point and using plain language. So your COVID test is positive. We actually had a situation during the height of the pandemic where we were testing people, and one person thought that positive meant a good thing because positive is good, right? We talk about that a lot. But positive in this case, as we know, means you have COVID. So we actually ended up adapting that FAIR to change what we were writing. And we just wrote, you have COVID, you do not have COVID. So just keeping in mind what your audience is and adapting is important. All right, so we're going to move on to some effective health education material. And I can't remember, Maya, is this my... I'm having a trouble remembering if this is my slide.
Same. I'm sorry.
I think I'll go ahead and start this and then you can wrap it up.
Okay.
So we use health education materials all the time, right? We have pamphlets, flyers. If they're not effective, they'll probably end up in a garbage can or on the floor, right? So we want to make sure that we're using materials that the patients can relate to and understand. So just some tips in general, like we said before, putting the readability of a material around 5th to 6th grade to make sure that it's universal understanding. The purpose of the material is clear, right? We need clear messaging, clear purpose. We want to avoid medical terms, like we've said, use common language. People's brains need organization, right? So if you can find material that's broken up into chunks that makes it easier to understand, that's better for people. The materials that you're using, they should identify at least one action item. So, the next care plan or whatever this step is next. Visual aids are always good, and used effectively is a good thing. And of course, be aware of confusing numbers. So we're going to take a second and look at some materials related to COVID. And I'd like to hear from you and your perspective on what you think. So let's go ahead and get started. So these 3 flyers are all related to vaccinating children. The one on the left is MDHHS, the one on the right is CDC, and the one in the middle is Authority Health. When you look at these 3 flyers, which one do you think would be most effective? And you all have different populations that you serve, but imagine these are language, if they're language appropriate or whatnot. What do you think about these 3? What about the main message? Which one has a clear main message, do you think? And there's no right answer or wrong answer. Okay, I'll start it off. So keep your cubs safe with this little bear and teddy bear. Do you think, does this seem clear to you as a message? Seems, okay, Maya's. So here we see keep your cubs safe. I think this is a good example of an image that works effectively. Parents understand this is to protect their cub. And the material underneath is, this is what it is. These are the children, and here's to call to set up that appointment. Now, the material is the same. This is keep the school year fun going, keep up to date, with your booster. And this one says COVID-19 vaccine is the best way to help protect children. But there's a lot of little words here, right? And I'm not sure if this is actually a clear message, keep the school year fun going. No, okay. Right, so you see the difference between these different messages. Okay, we're gonna move on now. This message, scientists have taken hundreds of steps to open this door. Would any of your members or clients that you care for or work with now, do you think this would be effective for them? Words like decades of research, months of clinical investment, scientists, doctors. Would this work for anyone? Think about this picture too. What is this? Any comments or feedback? Would this work? Okay. Probably not. And they actually translated this into all the different languages, what I thought was interesting, because again, this isn't necessarily something that will connect with some of our patient population. All right, the next 3, we're going to go quickly through, but these are all MDHHS released. And the reason why I wanted to show you them is because sometimes messages aren't clear. We need to have clear messaging. The booster, you can see here, there's a asterisk and another cross, and there's this. Anytime you have multiple asterisks in a message, it's going to confuse people, right? And we saw that with the booster, we still had a lot of questions. When should I get it? How should I, is it for me? What dose, so that's one. This message still confuses people. And I have people that call me on this still. So if you have COVID, remember, if you're symptomatic, you stay home for 5. Well, even if you're symptomatic, you stay home for 5 days and then you wear a mask for 5 days. However, for example, I'd have friends, again, see there's multiple asterisks. So it's like, well, this is confusing already. But I had multiple friends calling and saying, well, my daughter, her work wants her to come back because it's day 6, but she still feels sick and I don't know what to do because of this. So this was not, and I don't know how the audience feels, but when this rolled out, it caused confusion for a lot of people. And then the last one I just wanted to quickly show is, making a COVID plan. This flyer is not bad, but you have a real good action, right? Make a plan for vaccination, keep a supply of tests, keep a supply of masks, What about all this little print? All these extra information? Maya, what do you think?
Yeah, it's a little unnecessary. I do like the larger bullet points. And I do think that the flyer is eye-catching compared to some of the other ones, but I think it could have done without the smaller points.
Mhm. So, any questions on that? Okay, we're gonna do another one and Maya's gonna show us the next two.
Yes. Okay, so how do we feel about this flyer? This is another one from MDHHS. It says, why vaccinate your child against COVID-19? So let's just kind of adapt the lens of, let's say a parent going into a doctor's office, knowing what we do know about our population serves. If I'm a parent taking my child to a pediatric visit, how would I feel about this? What are your initial feelings about this flyer? There's a lot of information here, right? There's lots of small boxes, there's different, yeah, it's too many words. Thank you, Fatima. There's lots of words. Again, knowing what we may know about some of our population serves, there could be a language or literacy barrier. So there's lots of information on this flyer. So it could be overload.
Mhm. All right, and we commented before, these pictures, these are like the fear factor pictures, right? So that's another tactic that they're using. Okay, let's look at the next one. Go ahead, Maya.
Yes, definitely. Those pictures are a little scary. Yeah, there's one with a baby crying and one with a person in a hospital bed. So yeah. So yeah, a little scary on that one. So how do we feel about this one? This is a flyer from the CDC. So it's got some cute little cartoon kids at the top, you know, some pops of color in there. But again, lots of words, too many words. Thank you. Too many words.
Yes, for sure. Now this flyer and this flyer have exactly the same information on them.
Yes.
So this one's a little bit better because it does have some chunks in it. I feel that they try to kind of, but too many words on both.
Agreed.
Yes, agreed.
Okay, so does everyone kind of understand what we're talking about as far as the use of materials? Okay, great. Maya, I think you have one more slide.
Oh, yes. So I'm using health materials. So as we mentioned with the universal precautions, we're just going to assume that everyone has low health literacy. So don't assume that your patient can read that material. When reviewing a handout, circle the most important bullet points. I just remember my time as a community health worker. Sometimes the information that we have or the materials that we have are just the materials that we have. We don't always have time or the ability to recreate things. So circling or bulleting, highlighting what's important is good. Personalize the material by adding the patient's name, medication, etc., and use teach back to confirm understanding. We'll talk more about teach back later in the presentation, and emphasizing the importance of keeping the materials to refer to the follow-up with the patient. So encouraging them to keep those handouts with the notes on there. And I know a lot of times we do like to refer patients to online sites and apps and things like that, but it's important to make sure that the patient even has access to those digital materials when we're referring them out to those. Okay.
Thanks, Maya. Okay.
Oh, I'm sorry, one more bullet point on there. Obtain the patient's feedback on the material. So that could be as simple as, you know, are you okay with this material? How do you feel about this? That feedback, I worked some time in a place and they would always say feedback is a gift. So that feedback is definitely valuable so that we know for the next patient, this may not be the best material to use.
Okay, thanks. All right, so speaking of teach back, that was a great introduction. We're going to talk quickly about the teach back method. Now, teach back is something that if you haven't already been exposed to before, it takes some time to practice, right? So just like motivational interviewing, which we'll talk about at the end of later in the presentation. So my recommendation is that you follow up with some additional information if you're interested in learning more about it. YouTube also has, you know, a ton of great videos. Excuse me. So the reason why we are interested in this, and this is important, is 40 to 80% of medical information patient hear, they forget it immediately, and nearly half of what they do remember is incorrect. So we use something called teach back as a method to increase the understanding and help retain the comprehension. So I have a thing who's here has learned about teach back. Okay. So what is it? Like I said before, it's a way of checking understanding by asking patients to explain back what you just said in their own words. You do it with a caring way, with empathy. We're not quizzing or pimping our patients. We're just trying to make sure that we've been clear, and that's how we explain this. So it's a way to check for understanding, and if needed, re-explain it in a different way. So teach back as a method has improved patient understanding and adherence to treatment plan, decrease callbacks and canceled appointments, and improve patient satisfaction and outcomes. And the words of the day are empathy, I think. Using a caring tone of voice and attitude, plain language, of course, comfortable body language, and appropriate eye contact. As you know, not every culture, eye contact is appropriate for, and we'll go through that a little bit later. And then, of course, materials, reader-friendly print materials to support it. So we ask the patient to explain back in their own words, and again, emphasize that this is so, I know that I've explained it clearly. It's a thing on us, it's not the patient. Make sure that you document it. Okay, so here's a quick method graphic. So chunk and teach information. Ask the patient to teach back in their own words using the materials. And if they do, then you can move on to the next topic or whatever you need to teach them, or you can wrap up the session. If they aren't able to teach back correctly, then you just have to reteach using a different way, different words perhaps, or a different method. So Maya and I are going to do a reenactment. I don't know if that's really the right word at all, but we're going to do a teach back example. And so I'll play the healthcare provider and Maya will play the patient, and she's come into the office and has tested positive for COVID. So we're going to do the next few slides. Just imagine that the next few slides are a handout that I'm showing Maya. Okay. Now she has multiple conditions we have to talk about today, but we're just going to review Paxlovid today. All right, so Mrs. Campbell, as you know, your COPD and diabetes put you at higher risk for developing severe COPD. I'm going to prescribe you the antiviral pill medication called Paxlovid. This is what a dose of Paxlovid looks like. There's 2 pink pills and 1 white pill in each packet. You need to take the whole packet 2 times a day for 5 days. Oops. Here's some additional information about taking Paxlovid. I've highlighted the most important things, such as taking your pills whole. And here's a list of medications that you cannot take with Paxlovid. Are you taking any of these medications currently?
Yes, I do take St. John's wort daily.
Okay, I'm glad that we've discussed that. Make sure that while you're taking the Paxlovid that you don't take your St. John's wort. And here's some side effects to look out for. The most important thing is liver damage. Please call us if you have any of the symptoms listed here. And I've also circled the most common side effects. You can expect those to be mild and last a few days. So I'd like to make sure I explained everything clearly to you. Can you please tell me how are you going to take Paxlovid and what to look for?
Yeah, so I take a pill packet for 3 days. I need to take 1 packet 2 times a day for 5 days, and avoid taking my St. John's wort while I'm taking this medication. But I can't quite remember what side effects to look out for.
Liver damage is the big thing.
Oh yeah, that's right. So I'll give you a call if I notice any changes to my eyes or skin turning yellow, or if my skin gets itchy or my urine gets dark. I'll be sure to give you a call, doctor. Thank you.
Okay, so that's a very basic, just going through a teach back example. Like I said, you can look online. There's lots of different examples on YouTube to get better at practicing, but really just going through the material, showing the patients the most important thing, and then asking for comprehension. Okay. Okay, the next strategy is a quick one, and it's not really a strategy. It's not an evidence-based strategy, but it is something that I've done with my residents. So at Authority Health, I was the director of community medicine, and we did a project called Small Steps to Health. And actually started before the pandemic. We partnered with Libraries Without Borders, and we were doing health literacy in a laundromat at 7 Mile in Van Dyke. And every single weekend we went and did for 2 hours. The residents that were in training, you know, we would do a PDSA, but a continuous quality meeting every single week to figure out what worked, what didn't work. So it was really cool. We got a lot of information about how to engage patients in the community. But Small Steps to Health was a branch off of that project that we were starting in Narden Park, which is where Authority Health School-Based Health Center is. So really it was about small step behavior change. And that's the point of this whole review. We for 5 different conditions, diabetes, blood pressure, high blood pressure, physical activity, nutrition, and stress reduction, we had these huge posters to put up in the laundromat as well as little cards, and they were just small steps for each one. So for example, you know, we tell our patients, go exercise for 60 minutes, you know, 150 minutes a week, I think is the recommended exercise for adults right now. And I was looking at some charts recently, and I saw a doctor recommend 150 minutes of exercise a week. And I wanted to be like, what? So, you know, you tell a patient that they're going to not listen. It's just not practical, right? So work with your patient, do some motivational interviewing, which we'll talk about in a little bit, and figure out what small step or what's one small goal they can do, right? So setting small goals rather than saying, go out and exercise 30 minutes a day. How about what can you do in your own house? You know, can you, with your niece or nephew, can you put on some YouTube exercise videos and just dance in your kitchen for a little bit, right? There's a lot of people that can do that might not be able to go out and walk for 30 minutes. Same thing with like water, you know, this is, you guys know this stuff, but, you know, increase your water consumption. Everyone's supposed to be drinking so much per day. Well, for people like me who refuse to drink water, that's a lot of, but saying to me, can you drink 1 glass of water each morning before your coffee? I can do that. And that's a way to start drinking water. So just specific, concrete, you know, small goals is the point of the small steps. Any questions on that? All right, we're going to go over our 5th and largest, I think, strategy. And so Maya and I will talk through this, and then we'll take a short break afterwards.
Yes, thank
Everyone's still
you.
with us.
Yes. So health literacy strategy number 5 is consider the language and the culture. So fortunately, Wayne County is a large mix of different languages and beliefs. Some of the pictures here show Mexican town, Bangla town. So I love Detroit because it is so very much a melting pot. But with that melting pot, it's important to understand who's part of that pot. So who are our population served? So let's review CLAS, C-L-A-S. So CLAS standards, culturally and linguistically appropriate services. They are the framework to deliver healthcare services, respectful and responsive to patients' cultural health beliefs, preferences, and communication needs. And CLAS does promote health equity and reduce health disparities. Okay, so the CLAS themes, principal standard, governance and leadership in the workforce. I'm sorry, Dr. Custer, am I taking over your slide? Is this one yours?
No, this is just showing you the categories of the standards.
Okay. Governance and leadership in workforce, communication, language, and engagement, and continuous improvement and accountability. So much. Strategies to implement CLAS. So assess the language preferences and language assistance needs. So I know that someone earlier in the training mentioned interpreter services. So that's a big one. Use acceptable language assistance Do not use things that are unacceptable. We'll get into that a little bit in a different slide. Plan ahead for those interpreter services. So that is, as a CHW, for me, what that looked like was looking ahead in the week. So looking at the schedule. So knowing on Wednesday, our patient that comes in, she does have a language barrier. So that means we need to have that interpreter services queued up. Provide written materials in the patient's preferred language. Respectfully ask the patient about their health and belief customs and beliefs. So don't assume that just because a patient is from a certain group that they practice or that they don't. Avoid stereotyping based on religious and cultural background, and acknowledge and address our own implicit bias. Okay. So some language translation services, some do's and don'ts. So we do want to use bilingual clinicians and staff whose proficiency has been confirmed. And we do also want to use staff who are trained as interpreters, on-site trained medical interpreters, or telephone or medical interpreter services. I know not every doctor's office has an interpreter or a staff member who is trained on staff, but there are interpreter services. We do not want to use clinicians or staff who have not been trained or certified as medical interpreters, or patients, family, and friends. I see this very common that patients, family, and friends will come in, which is great. It's great that they have that support, but it does pose an issue with the patient's privacy. Respect choices for qualified interpreters present, and minor children should never be used as interpreters. Thank you so much.
Yeah. Okay, this website is a U of M care guide. They have taken some time to put this together. The link's right here. You'll get the slides after. And I just bring this up because they have put together handouts. Either they've written them themselves or they've pulled them into their database for, I would say, every single condition you could think of. This is just one page showing the different languages that are available. So go ahead and take a look if you want to see if there's good materials here that you could use. Of course, MDHHS also has COVID-related materials in different languages that are available. If you think these would be helpful, there's a link to those. All right, so that's language, right? We want to make sure that we're addressing the language preference and we're using the language preference. Culture is another thing, right? So let's talk a little bit about cultural competence. So we know that religion, culture, beliefs, and ethnic customs can influence how people understand their health, how they take care of it, and how they make decisions. Cultural competence relies on the principles of trust, respect for diversity, equity, fairness, and social justice. So what we've been talking about throughout this presentation. And of course, considering culture can help clinicians to make better engagement with their patient, better patient-centered treatment planning, consistent with the values of the patient. So there are lots of different ways that culture can impact health engagement. So we're just going to review a few, which I'm sure some of you are familiar with. So health beliefs. So in some cultures, people believe talking about a poor health outcome can cause it to happen. So you have to be aware of that. Some cultures, family members play a large role in health care decision-making, especially sometimes elders in the family. Mm-hmm. Roles of women and men may shift depending on where the person's from. So it may determine who makes the decisions about what treatments are followed or accepted. Religious beliefs, religious faith, and spiritual beliefs may affect how someone uses healthcare or willingness to accept specific treatments. Dietary customs, sometimes we are recommending diets, for diabetes or hypertension or whatnot, but we may be recommending food that our population that we're working with doesn't even know how to cook. Right. So we have to consider the dietary customs of the person we're working with. And if what we're saying is unfamiliar, cooking matters classes, I love those. Interpersonal customs. So eye contact or physical touch may or may not be appropriate. It's important to know with your specific population what is considered, appropriate or offensive. I mean, even showing the bottom of your shoe, right, can be totally inappropriate in certain ethnicities. So we want to make sure that we are aware of who we're working with. And that's when we get back to the health literate organization. Especially in Detroit, we have so many different populations. Just knowing the population you're serving and making processes and policies that reflect that you understand that, right? Implicit bias, again, this is something that I'm sure all of you are hearing about. A lot of companies are requiring the training, right? We all have implicit bias. We all are raised in our own families, in our own circles of I almost said circle of life. I don't know what I was talking about for a second, but we all have our worldview. We're raised in where we're raised, how we're raised, what we believe, what we think. And really implicit bias is something that serves as a human defense mechanism. I mean, back in the day when we were hunting and gathering, it was important to stick with those that looked like you and avoid the enemy because you didn't want to get eaten, right? So implicit bias is something that's within all of us. It's something that we need to go ahead and look into ourselves and say, can I treat or can I engage with this population, this person appropriately, or do I have biases? So just to be able to take a look into your own beliefs and understanding. So let's talk a little bit about this. So trauma-informed service, I'm going to go back quickly. The next few slides, these are things that you could do a whole course on in a semester. So we're going to blow through a couple concepts that are very important to understand when having cultural humility. And I encourage all of you to follow up with additional trainings if you would like more information. Of course, implicit bias is the first. Trauma-informed care, trauma-informed service is the next. Has anyone read this book, The Body Keeps the Score? No? Okay. I highly recommend this book. It was a game changer for me in understanding how trauma can impact the body. The question is, who here has heard of toxic stress? Right. How about adverse childhood experiences, ACEs? Okay. So, through our time, we understand that trauma and toxic stress impacts the body, both physically and mentally. Toxic stress, we have a fight or flight mechanism built into our body, right? And that fight or flight mechanism gets activated when we're stressed. Toxic stress is when that elevation, and it's specifically the cortisol, and your body is up, 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 and it never comes back down because you're constantly exposed to stressful situations. And so when we talk about adverse childhood experiences, things that children might be exposed to in childhood, that can be toxic stress that can impact health. Things like PTSD, things like war or disaster, those are also toxic stress, right? So when we talk about trauma-informed or culturally humble services, we need to have an awareness of all of this. Maslow's hierarchy of needs, again, another topic that we can spend a whole day on, but Maya, you can please join in and at the end of the day, go ahead, Maya.
No, I'm sorry, I didn't mean to cut you off.
Go ahead.
So I love the Maslow's hierarchy of needs because when we get down to it, it is a true reflection of some of the things that our patients are going through. I know during the height of COVID, a lot of our patients were discussing how they felt isolated and alone. So as a community health worker, there are all these resources, in the community to help them, get outside and get involved in groups. But then it's difficult to talk to a patient about going to a walking group when they're facing eviction or their children don't have clothing. So it's like those bottom needs, that food and safety, those have to be met in order to move up the pyramid. So I can't talk to a patient about the mental health when they're going through domestic violence, because that domestic violence and that need for safety supersedes their need for love and belonging. So as a community health worker, sometimes that's digging deeper, asking some of those questions, to really get to the meat and potatoes of the situation. What's really going on? What can we really help you with? So that I think that this is a good thing to keep in our toolkit as community health workers.
All right, thank you, Maya. This illustration comes from Dr. Dietz, who is from George Washington University. If anyone here knows about the Motion Coalition at Authority Health, he was the co-chair or is the co-chair, but he developed this model, and we talk a lot about adverse childhood experiences. And this demonstrates the pair of ACEs. So, we can't solve adverse childhood experiences without working on adverse community environments. So at the end of the day, we need systemic change to take away all this inequity that's been built basically on the tenet of white supremacy. And we need to, clean up. So every time I talk to the kids at U of M, I'll, do a lecture to students that are young. I show them this slide and I said, this is what you guys have to do. This is what we're up against. So everything that we work on social justice wise is to take away these adverse community environments. It's a big job. It's a lot of work, but we can do it. And, the last thing I wanted to kind of quickly go through when I do I do a trauma-informed service lecture workshop with students that are working with clients. So we go through this list of questions, and I'm just going to ask them out loud, and then we'll take a quick break. And you can substitute trauma for culture or for life experience. Have I considered the trauma this person has experienced? Am I creating a safe place for this person to share? Safety, feeling safe is essential, to be able to share effectively and build trust. Do you have any bias, unconscious, conscious bias? Can you even be unbiased? These are things you have to look at yourself and understand. How does your background, history, etc., impact your ability to serve? Are your actions making others uncomfortable? Are the words you're using respectful and culturally appropriate? And are you listening, or are you just talking or listening to talk? So these are all things that we need to think about when we're serving. Any questions about this? Okay. All right, we went through some heavy stuff. So again, I encourage anyone to follow up for more information on any of that. We will go ahead and take a 10-minute break. And actually, I think we can do it. Well, do you want 10 or do you want 5? I'm good with either one. 5? Okay, Claudette spoke for the group, so we're going to take a 5-minute break. I'll go ahead and pause the recording, and when we return, we'll get back to the rest of it. All right, let's see if I can pause.
Yes.
Great, thanks, Maya. Okay, so we're going to come back and talk about some strategies to overcome vaccine hesitancy specific to COVID-19.
Oh dear, I can't get back in there.
Okay, so vaccine hesitancy is, as you may know, defined as a delay in the acceptance or refusal of vaccine despite availability, and it is one of the top threats to global health. And there are few effective strategies to address this problem. So what are the causes? A lot of the stuff we've already reviewed in this training: healthcare and socioeconomic inequality and equity, lack of effective public health messaging. We talked a lot about that earlier. Unethical research involving ethnic minority groups, structural racism. In the past, before we had research protocols in place, there was unethical research being done with minorities. We know about that. So that's a big cause of mistrust in the medical community. Social disadvantages, like we've talked about, lower levels of education and access to high quality information. A huge thing that we are going to talk about in a second is the growing spread of misinformation, disinformation, and conspiracy theories. It's always existed, but now we have so many different online platforms. It's easy for people to get information quickly. And then, of course, barriers to access could also be a factor, not so much in Detroit. Very, very quickly, the primary series, as everyone knows, for the COVID-19 vaccine was a monovalent, meaning it covered the one strain. Depending on which company you got, you either got 1 to 3 doses, and it was recommended for everyone, right, ages 6 and over. Now we have the booster. So the booster is bivalent, meaning it covers 2, both the original strain and the new Omicron, it's not new anymore, variant. And it is also recommended for everyone 6 months and older. We're going to go through some information specific to the COVID vaccine statistics in a few minutes. But we'll start now with some CDC recommended strategies. This field guide came out last summer. It was actually pretty helpful. And there is a link to all the, like I said, at the end of this presentation, there's a resource link. So 2 of the strategies out of the 12 that are helpful, we're going to go through motivational interviewing and combating misinformation. So I'll turn it over to Maya to start with motivational interviewing.
Thank you so much. So I had the pleasure of learning about motivational interviewing. It's been several years at this point, but I absolutely love it. So motivational interviewing is a guiding style of communication which balances good listening with good advice. It's designed to increase the patient's motivation and likelihood for health and behavior uptake. Is based on respectful and curious ways of being with people that facilitates a natural process of change and respects patients' autonomy. So I do have to say that I use motivational interviewing at this point, like in everything. So I think a lot of us do, and we may not know it. So I absolutely love motivational interviewing. Okay, so let me just make this a little bit bigger. So the spirit of motivational interviewing, a partnership between the patient and the practitioner is formed, joint decision-making occurs, and the practitioner acknowledges the patient's expertise about themselves. I like to say, simply put, the practitioner is the medical expert, but the patient or the client, they are the experts on their own situation. So patients may not realize that, but they know themselves better than the practitioner. The practitioner activates the patient's own motivation for change by evoking the reason for change. The practitioner connects health behavioral change to the things that the patient cares about the most. A good example of this, I had a patient who she was very resistant to doing her diabetes testing. Understandably so, no one wants to poke themselves, and that's all she kept thinking, I don't want to poke myself. But then she did also express that she loved and cared for her grandchildren and wanted to be around. So I connected those two. Hey, we have to get this diabetes under control so that you are present for your grandchildren and you can dance and you can go on those walks with them. That was very important to her. But I only learned that through active listening and motivational interviewing. So the last point on the spirit of motivational interviewing, although the practitioner informs and advises the patient, they acknowledge the patient's right of freedom to not change. And it's really up to the patient. So that's the spirit of motivational interviewing. On the other side of this chart is the authoritative or therapeutic style that practitioners have traditionally taken. The confrontation, or the practitioner assumes the patient has an impaired perceptive, and consequently imposes the need for insight. So basically the doctor knows best. Education, the patient is presumed to have a lack of insight or skills and knowledge to change, and the practitioner tells the patient what to do, and the practitioner instructs the patient to make the changes. So I like to think of this as my grandmother and my great-grandmother. They didn't question things that the doctor said. The doctor knows best. I trust my doctor. It's like, yeah, I trust my doctor as well. But again, we are the experts on our situation. So the doctor may have, the expertise on the medical part, but I know what things work best for my lifestyle and my family. Okay, thank you. So the next part is ORS. This is a big part of motivational interviewing. So asking open-ended questions, affirmations. I'm sorry, I'm going too fast. So open-ended questions, go ahead. Asking questions that invite conversation, or questions that are not yes or no questions. So explain to me or tell me about or say more about, those phrases do help encourage that conversation. So affirmations, recognize and reinforce the success. Even when this is a big one because I think at times patients don't always see the things that they're successful in, even if, especially if they experience lots of trauma, they tend to focus on, I've been through a lot, but it's good to reinforce, you're very resilient. You sound very brave. That is very strong of you. And be sincere about those things, because that sincerity does come across. And all of these things do help build that rapport. Like we talked about earlier in the conversation, that relationship piece is very, very important. Thank you. So reflections, mirror what the client says. So use their own words. Clearly, those are things that they understand. So listen and mirror what they're saying. So use phrases like, it seems that, or it must be, what I'm hearing you saying is, phrases like that. And summarize. Let the client know that you're listening. So just like in the teach back method, it's kind of the teach back for us. So reading back what the patient said. So letting them know, I'm hearing you, I'm listening for understanding, and I'm not just here in the room with you. So thank you. So motivational interviewing strategies to discuss COVID. I'm sorry, Dr. Chris, is this my slide? I don't want to take over your part.
I think this is your slide.
Okay. So we're starting with open-ended questions about the vaccine. A soft start to a controversial topic. So what are your feelings about the COVID-19 vaccine? Acknowledge the patient's concerns without being judgmental. Empathy reduces the perception that you approve or disapprove of someone, because we don't want to break that relationship by saying something that may be offensive to them. Avoid criticizing the patient's information source. So this is a big one as well, especially in some of our communities of color. Our elders are most important, but for, the COVID is a new thing. So our elders may not have all the information. So not criticizing and saying, that's wrong, who told you that? Because it could come from my grandmother that we look at as just absolutely gold in our family. And now the relationship between the practitioner or the community health worker and the patient is broken down because I've said something offensive about an important person of my community. Unknowing, but just keeping that in mind. So show awareness of your status as a messenger, especially for those communities of color. Who you are as a messenger matters. Because as a community health worker, we are the boots on the ground. We are the smiling face for the patient. We are the person that's coming in and checking on them. And many times we're the person that's even confirming the appointments or, reaching out. So it's important to acknowledge that, our role as a messenger. And link the vaccine acceptance to the patient's hopes and goals. So if we think about the patient that had the grandchildren, letting her know, hey, you want to be around for those grandchildren. So getting that vaccine and staying healthy is important because you would hate to pass that to the grandchildren or not be able to be around them. So that's important.
Okay, so what we're going to do another clinical scenario. And so we'll do a motivational interviewing, and I'll be the healthcare provider and Maya will be the mom. And how we're going to do it is we'll do an example of a traditional approach talking about vaccines versus using MI. And like Maya said before, and I can confirm because I'm a physician, in the past, it was always, so paternalistic. The doctor knows best. The doctor knows best. And we know that that's not necessarily, the doctor does know a lot, but we need to work with our patients to create shared plans. So let's go first through this scenario where we do a traditional approach, which is based on education and counseling. All right, Maya, Mrs. Campbell, it's important to immunize your child. If not, you're putting him in danger. Do you know there are still cases of measles? This disease can be very dangerous. And what about meningitis? It could be fatal, You should update your child's vaccinations as he is already late according to the schedule. We could do that now if you want.
Yeah, I don't see the urgency, and autism is way worse than measles. There's more problems and solutions with this vaccine. Moreover, it's completely unbelievable to give so many vaccines to a child all at once at the same time.
Well, actually, studies have demonstrated there's no link between autism and the measles vaccines. The vaccine is safe, I assure you. You should be aware of the information you're finding on the internet. Giving several vaccines at the same time is safe and not associated with more pain. We should update now.
Well, I heard something else, and I'm not only from the internet, I do read, and the vaccines are not mandatory, and ultimately I can do what I want.
Yes, you're right. It's not mandatory, but you're putting him and other children who cannot receive vaccines in danger. The risk of disease are much higher than the risk of vaccine. If I'm taking this time to speak with you, it's because it's very important. Oh, our patient's muted.
Oh, I'm sorry. That's easy for you to say. Everything is so quick. But what if he gets autism? I'm worried about the risk of that, but you don't seem to be worried about the true health of my child.
Of course I am. And I'm worried about the fact that he could get diseases that can be prevented by vaccines.
Yeah, I don't think that we're on the same page and that we're understanding each other. So let's just talk about this at another time.
Okay, so I adopted the role of an expert, right? And I used a directive intervention approach based on argumentation and writing the mother. And this led to an opposition. Okay, so we're going to do it again now, and we'll use a motivational interviewing approach. Mrs. Campbell, what do you think about the advantages of vaccination?
Well, I know that vaccines protect children against several diseases that we don't see anymore. My child received all his first vaccines, but I'm worried about the measles vaccine specifically because I heard that it could cause autism. For other vaccines, I have fewer doubts, but for that specific one, I'm still hesitating.
As you said, vaccines have reduced diseases in such an important way that they're now much less frequent. It's why you vaccinated your child when he was a baby. If I understood you correctly, with the exception of the measles vaccines, other vaccines seem safe to you?
Yes, I know it's a good thing to prevent those infections, but about measles, I'm conflicted. I've read a lot of books and articles on this, and lots of people are worried about the link between measles vaccine and autism.
So you find it's important to protect your child against diseases when the vaccines are safe, but you're worried about what you've heard regarding autism and measles. I see you've done a lot of research regarding autism about the subject. If you agree, I can give you some additional information about the studies on autism and measles.
Sure, I want to know exactly what's going on.
Great. In fact, you're right. One study had hypothesized a link between vaccine and autism, but the study was fake and the author lost his medical license. More than 500 studies have been done since then around the world, and they've demonstrated there's no link between vaccine and autism. The frequency of autism is the same in a group of children that received the vaccine and the group of children that didn't receive the vaccine. What do you think?
Wow, well, so I'm not so crazy to be worried about that?
Of course not. You're totally right.
Well, thank you so much for taking the time to understand my concerns, and I'll think about it a little bit more clear now.
Okay, so this presentation or motivational interviewing allowed the mother in a non-judgmental way to express her concerns, and the health provider was able to give solicited information that could be accepted by the mother. So basically, I'm eliciting how she feels, how her understanding, her wants, her desires, and guiding the information so that she can receive the appropriate information and make a well-informed decision, right? So again, just like I said for Teach Back and the other things in this lecture, please feel free to go ahead and do some more training on motivational interviewing if you haven't learned about it before. MI works really, really well, like Maya said, but it takes practice. I remember the first time I learned it and I practiced on my family. So, just do what you got to do to get better at it. It's a really good technique. All right, our last chunk to cover today is misinformation. Does anyone know the difference between mis or disinformation? All right, I'll go ahead. So basically, this was just kind of a quiz question. Misinformation, they're both not correct information, right? Misinformation is released, but it's released in error. People don't realize it's false. They think it's true, right? When they're sharing it. Disinformation is made up and clearly false, and is made up in a kind of a violatory way that is meant to confuse people. Okay, just so you know, that's a difference. We're going to talk a little bit about social media and the importance of trusted messengers, which we've touched. So this slide, this is the social media landscape in 2022. The point of this slide is just to see, holy cannoli, how many different sources of information are out there today. And, you know, depending on your age group that you're working with, you may be, it may be a Meta, or it may be Tinder, or no, let's not go there, but just to show you that, you know, there's a lot of different places. So we understand why there's misinformation and maybe even disinformation at times. So again, like we've talked about with MI even, dissemination, the best thing you can do is not argue the misinformation, right? Don't argue, don't judge. Just use credible sources to demonstrate facts. Now, this can get a little tricky because there's people now that don't trust, and there's people that never trusted the medical system, right? So they might think your credible source, the CDC, for example, isn't credible. So you do have to think about that as well. But really just focusing on the facts and using trusted messengers. As CHWs, you are kind of trusted messengers because you do advocate for your patients. But there's, you know, a lot of, we've seen it over the past couple of years, a lot of people have used celebrities or, you know, pastors or even neighborhood champions to kind of get the messages out. These are good strategies if you have trusted messengers to use. The next two slides I just threw in, I wanted you all to see the accurate information. This was pulled in February. This report came out in February, I believe, or maybe January, but it shows the up through November 2022. And for hospitalization, and again, these numbers may not impact your population. People might not, this might not change their mind, but it might. You know, it might be helpful to show that people who have been vaccinated are at a much lower level of being hospitalized than people who are not. This is still true, right? If we look at the amount of death, we can see that the unvaccinated, although it's, you know, we know that with the strain changing, COVID's not necessarily killing as much as it did. It's not as severe, but it's still very virulent and lots of people are getting it. And it's a nasty cold and some people are still dying, right? So this slide just shows the unvaccinated death and the vaccinated death. And here we see the Omicron. And with the Omicron booster, the chance of death is almost zero. So this is the accurate information that we have right now that we can show people. Any questions on that? Maya?
Yeah, so thank you. So I love this part of the presentation because we get to open it up and have some dialogue. Share a situation where someone refused to get vaccinated because of mis or disinformation. Does anyone want to share an experience, or how did you react? Was it effective? And consider a time when a patient refused the vaccine. So does anyone want to share any of these experiences? Feel free to unmute and if you would like to share. Okay, go ahead, Claudette.
Can you hear me?
Yes.
Oh, okay. I'm a senior, and many of the folks that I had interacted with were a little surprised that I had gotten the shots. And I said, you know, you need to do this. It's just as if we were back in school again years ago. We didn't expect that we would have it, but our parents made sure that we did get the inoculation. So at this point, oh, it says I'm mute.
No.
Oh, can you hear me?
Yes.
Oh, no.
Yes.
Oh,
we can hear
okay.
you.
All right. My screen is showing mute. Okay. So anyway, I went on and got it. I didn't have any problem. And I'll be, 80 this year, Lord willing. Yep.
Well, Amazing. And I don't know when your birthday is, but happy early birthday.
Oh, thank
And
you. Thank you.
and thank you so much for sharing that. And also thank you, Ms. Claudette, for being that advocate for the community and sharing your experience, because that experience is gold. You know, to be that face in the community to say, you know, it's your decision, but this is what I did and it worked for me, and
Right.
I'm still here. So I know I have a teenage daughter and
Mhm.
she's super funny. But she was very convinced that during the pandemic, it was like the zombie apocalypse and that
Mhm.
the world was collapsing. And this was all information that she had gotten from TikTok. And even though it sounds super strange to us, my daughter values TikTok so much. So
Mhm.
I obviously it was not the zombie apocalypse that she was hoping for. And the vaccine did not turn anyone into X-Men. We don't have superpowers for getting the vaccine. It was important that I didn't diminish the importance of those social media outlets, but
Right.
I did just challenge her thinking, you know, hey, we obviously have no ability to fly at this point. And we had the vaccine and we're perfectly fine. So it's something to think about, you know, when you're absorbing that information. Is this a trusted source?
Mhm.
So it did open up a conversation in my house about just sources of information.
Mhm.
So again, thank you so much, Ms. Claudette, for sharing that.
Oh.
And that is really important.
Mhm.
Does anyone else have anything to share regarding vaccine mis or disinformation?
Yeah, so my sister, I don't know where she hears what she hears, but I would just like talk to her about, what I knew about it and what I had found out about the vaccine. And so it actually got her thinking. She still hasn't received the vaccine, but she like instead of just completely like being like, okay, well, I'm not going to even think about it, I don't want anything to do with it, she was like at the point where she was considering and actually made an appointment and then ended up backing out. But, I've just been slowly trying to like talk with her about things. Like I never once told her, well, that's just dumb. Like that's not that's not true. But I would say, like this is what I learned, and it made her like want to learn more about it. But it's still like there's still hesitancy there. So.
Sure, and thank you so much, Andrea, for sharing that. But as you know, as the boots on the ground, and you know, the community health worker, and even as providers, it's not our position to force a person to do what we feel is best for them. As the spirit of motivational interviewing, it's about what they decide is best for their situation. Again, they are the experts in their situation. So, but with that being said, we want them to make the most informed decision. So we want their decision to be based on facts and not, you know, rumor, internet myth, or a cool TikTok dance. So that is very powerful. So thank you so much. Do we have anything else? Does anyone have anything else to add here?
Well, thank you for sharing, everyone. All right, so I think we have time. I'm excited. We're going to go through a quick case. And Maya and I, this is our first session that we've actually been able to do this. So we're really excited, especially for the people online. So we'll do a case. This is the case of Eliza. I'm going to read the script and then we'll do some questions. So Eliza is a 77-year-old woman, and she's been diagnosed with long haul COVID after experiencing rapid heart rate, shortness of breath, and fatigue since she was hospitalized with COVID-19. She sits in her doctor's office listening to instructions and going over the next 3 months worth of treatment. The doctor assumes that she must know most of what he's talking about since she doesn't ask questions and tells her what she needs to know after a few instructions before her treatment begins. What the doctor doesn't know, because she's kept this a secret for as long as she can remember, is Eliza does not know how to read because she dropped out of school when she was 8 to help her family farm and never went back to learn. She has little medical background and barely knows anything about heart disease. He gives her pamphlets and written instructions that tell her everything she needs to know, but doesn't tell her much about what the papers say. He says to let him know if she has any questions, and she responds with, "Okay, I will." Unfortunately, she can't read the material and is too embarrassed to admit she cannot read the information. which will lead to problems in continuing her health plan properly. So a few questions about this case. If anyone wants to go ahead and did you recognize any red flag behaviors, the things that we talked about earlier in the session?
I think the head nodding and lack of questions is definitely a red flag. Not always, but I think that in Eliza's case, it was definitely a red flag.
Yes. This is not supposed to be diabetes, it's supposed to be COVID, but how, so how does her limited health literacy, how can it impact her care?
She may not follow through on like doctor's appointments, testing, things like that, because she doesn't truly understand how those things are connected. And I think in the case study, it said that she doesn't really even know much about heart disease at all. So.
Right. Right. So if it wasn't running in your family, how would you know about it? Right. Okay. So how could the provider organization been more health literate? So remember we talked about earlier that slide with all the wheel with the spokes. There's lots of things they could have implemented to become more health literate. Of course, assessing the patient's level of understanding, making sure that the materials are effective, going through the materials with her, and asking open-ended questions about understanding or teach back even, right? So there's a lot of different ways that the provider organization can be more health literate. All right, that was our quick little case. Go ahead, Claudette. Oh, you're muted.
Do you think the doctor's office process in terms of limiting a certain amount of time, 15, 20 minutes per patient, impacted this particular, because it's apparent to us that she needed more time to have some one-on-one, but that wasn't an option offered. And my thought is that on the doctor's end, they're concerned about the numbers turning over how many they interview or process.
Right. So timing of the appointment is always an issue. And that's why we're promoting team-based care now. The team-based care model is amazing. The nursing staff, the medical assistants, even everyone, the CHW, which is probably the most important part, right? All work together in assessing patients and making sure that there's time for education and time to explain things like this. So yes, thank you for making that comment, because it's all too familiar with us, how doctors will just rush. And so that's why we're doing these trainings. And that's why training residents now that are coming out of medical school, this is a big priority. Because if we train them correctly, then it's built into the way that they interact with patients. So
right.
Those are just some of the things that we're working on. Well, we as in all of us. Any other comments or questions? Okay. Well, thank you. Back to Maya.
Okay, so the summary and the key takeaways from today's training: low health literacy is associated with lower health knowledge, poor medication adherence, increased use of ERs as a primary care, increased mortality rates, which all of these things impact the patient's quality of life. It is important to use those universal precautions. So as we discussed earlier in the training, just assume that everyone has low health literacy, the same way that we use those universal precautions with blood. So you would assume that every drop of blood is contaminated. Improving the individual and community health literacy levels can reduce vaccine hesitancy and increase COVID-19 vaccination rates. The final review. Recommended grade level for all written materials is 5th to 6th grade. So that kind of encompasses our national average. I believe it's 8th grade literacy level. Health literacy strategies can be used to increase the patient's understanding about their health condition, empower them to take a more active role in their health. And we do this by using the methods we discussed in today's training, clear communication, teach back, using linguistically and culturally appropriate materials, motivational interviewing, and combating that mis and disinformation. Okay. All right, so here's the contact information for both Dr. Custer and myself.
And we will, so after this presentation, you'll receive the slide set and the link to the recording. And I'll come back to this. I just wanted to quickly show you, there are some additional trainings. This is a CDC based one that's pretty good that you can sign up for. And these are the resources that we talked about. So links to all the things that we mentioned throughout the presentation. If you have time, we would really appreciate if you could go ahead and either scan this QR code, or Maya's putting the link in the chat box for the post-session evaluation. Yeah, I know not everyone likes QR codes. I don't necessarily either. So when you do, if you would like to, part of the post-session evaluation is feedback on our presentation, as well as an opportunity to get a certificate of completion, as well as some CEUs from Wayne County Community College District. You can also get your MSHWA 2.0 registered hours as well. But in the post-session, it will ask for some information about you, your name, phone number, etc. We do need that information if you would like a certificate from Wayne County Community College District. So for the people that are listening online, we're going to go ahead and stop recording now, and we just thank you for participating. And I will, and for those who aren't